Hi everyone, Jennifer Blevins-Smith with Integral Clinic Solutions, and you're watching my YouTube channel, Navigating the Business of Medicine. Today I want to talk about drug pricing and profitability. Have you done a cost analysis to see if what you're getting paid from insurances on all the medications that you bill out is actually making you money? Would you be surprised to hear that a lot of people actually lose money, but they don't do a cost analysis very often to be able to prevent this or change this? Are you aware that the drug prices and reimbursement is actually set by CMS? Today, we're going to talk about what an ASP is, who sets the drug prices, how much practices get reimbursed, and what you need to look for to make sure that you're making some money. ASP, or average sales price, is what CMS comes up with when they are determining how much they are going to reimburse for a medication. The average sales price is actually also the average of the price that includes discounts and rebates. You have to keep that in mind. Usually Medicare will reimburse the average sales price plus 6%. So you would get the average sales price, you do the 6% math, and then that's what they reimburse for Part B. What you might not be taking into consideration is that you have to take the sequestration discount off of that. So usually instead of 6%, it's more about 4.3% per the notes that I have here. The ASP is used as a benchmark to determine fair reimbursement, but it doesn't account for every clinic's unique cost structure. That is something you need to be aware of as well. ASP does not mean what your clinic pays or the cost for the medication, and a lot of people get that confused as well. ASP is the national average, but you, as a consumer, as your practice, may pay more or less based on your group pricing, if you're part of a GPO, your organization, your volume, contracts with the vendors, etc. The first thing you need to do is find the ASP pricing. This can be found on the Medicare website. I will put the link to the page where every quarter's ASPs are listed so that you can go there, bookmark it, and make sure you reference this often after you watch this video, of course. And you're gonna go find the current quarter's numbers. We are now in August of 2025, which means we're in the third quarter of the year. You are going to look up the third quarter of 2025's Excel sheet. It's a zip folder and you download it and then you extract it. And once you open that Excel, and I will show you some examples here as I'm talking, you will go in and you will put Control F or use the find function and look for the J codes that you bill out in your practice. You would want to keep a list of all of the ASPs that are listed here. Something to note when you're looking through this document is that the prices listed are per HCPCS billing unit. That means that the price listed is per unit, not per vial or per syringe, unless your vial or syringe is a billing unit. A lot of times a syringe or a vial is multiple billing units. So you need to keep that in mind when you're looking at these prices. A lot of people's hearts drop when they see J1885 is only reimbursed this small amount, but then I go, okay, but how much is a standard dose? And they go, well, it's this many milligrams or it's this many milliliters. And you do that pharmacology, hopefully you have that background, conversion, and you go, oh, okay, so I bill out 10 units or 15 units, so I actually bill out the amount listed here times that many units, and that's how much total charges go out. This is something that you need to be mindful of. The short description is usually the generic name for the medication if there's a generic name available. The ASP per unit is what CMS uses as the base payment rate. And the payment limit column that you'll see is what Medicare will reimburse. Okay, so if I were you, pause this video right now, go download this file and keep it and just kind of look at it while we're talking about it, and then resume the video just so you have some context if you're not familiar with this already. When I worked in the practice, I would buy many drugs from a wholesaler like McKesson or Cardinal or Henry Schein. And depending on the medication and our volume and how much we used it on an average basis, I would order so much. Some of the medications, we got a discount if we ordered over a certain amount. Other ones, there wasn't that ability. Some of them had rebates that came with it. Some of them didn't. It was always changing and something I had to watch very closely. Once you have the ASP pricing for your drugs, the next thing you need to do is go and see how much you're paying for these medications out of pocket. Now, the second step is very important because you need to have the previous information for ASP plus this information plus the next step we're going to talk about is reimbursement in order to see if you are making any money in your practice. You need to look up your invoices for the medications. You need to make sure you're considering, like I said, what a billing unit is versus the unit that you're purchasing. So if you have a multi-dose vial, if you're buying a large lot and getting a discount based off your volume, if there's rebates, those are all things that you need to consider when it comes to the bottom line of how much you're paying and comparing it to how much you're getting reimbursed. It's not going to do you any good if you don't consider the billing units to the actual amount that you're buying and doing that changeover, because you're going to get really confused and you're going to get incorrect data. So I have a little bit of an example that a medication, the ASP is $75 that CMS will pay per 10 milligrams, okay? You administer 100 milligrams, which that's 10 billing units. So you're billing out $750, right? 75 times 10 units, $750. You're billing out $750 because 10 units times $75 per unit charge is $750. But you look and see how much you're paying for this medication at McKesson, and you're paying $800 out of pocket. Well, I can tell you right now, without even looking at your other payers, that with specifically Medicare insurance patients, you're losing $50 a patient. That is significant. That is a lot of money because it adds up. A pro tip is that sometimes, and I just kind of alluded to this, ASP is below your purchase price, especially for biologics because they are more expensive, or when you miss out on the 340B discounts. Some things just to take away from this second step is that the billable units is not necessarily your vial size. And you always want to check your NDC to HCPCS billing units. So now you have this data, you have the ASP plus the markup from Medicare, you have your payments of how much you pay for the medication from a wholesaler. But the third step is that you need to check your billing and how you're getting paid. The first step is making sure you're billing high enough, right? We just went through how to determine what the ASP is plus that percentage. So you want to make sure you're billing over that to account for your allowables. Remember, Medicare is probably going to be one of your lower reimbursers depending on your commercial insurance volume mix. If you have a lot of commercial patients, then based off your individual contracts with them, it probably is a little bit more, just like your other CPT codes. However, The next step of this is running a report out of your practice management system to see not only what you're charging per unit for every medication, but how much is your allowable for every unit of the medications. That is the kicker here. And you want to look at it based on payer. You already know pretty much what Medicare is going to be, but you should make sure that you're getting reimbursed what you're expecting to. But you also need to look at your Blue Crosses, your Medicare Advantages, your United Healthcares, your Cignas, your Aetnas. TRICARE is a good one, even though they should follow Medicare. But again, you still can't assume, and you need to check. And this is exactly what you need to do for every medication, including vaccines, because those charges and costs are on the ASP as well, that you need to go through. And I encourage you going through. The prices change once a quarter. Unless it's a new medication, it's not going to change that much. So doing it twice a year just to evaluate and make sure everything looks good, not only from reimbursement and what you're buying it for, but making sure your insurances are paying what they should be per your contract, is always a good idea. So first, what you need to know is that payers don't often reimburse your full billed amount, right? You have to have those contractual adjustments. And they reimburse based on their own fee schedule, your allowables per your contracts. And sometimes it's tied to outdated ASP pricing. So if you're noticing that your insurances aren't reimbursing high enough, or certain insurances aren't, I should say, you need to go to them and you need to say, look, this is how much the drug costs me. This is the ASP. This is what Medicare is paying me, and you're paying me less than that, or whatever you want to provide to them to increase your reimbursement. You need to do that. You don't want to just stop giving the medication or refer patients elsewhere. You first need to make the attempt to go to the insurance company and give them the opportunity to make it right. Before I jump into that a little bit further of solutions once you find this, you have to make sure that you're billing out everything correctly before you jump to the conclusion that the insurances are shorting you. The number one thing I see often is that there aren't enough units being billed for the medication. Either the person entering the J code or the medication CPT code doesn't realize you have to update the units based off of the dose, which is very common. They're not aware that there's a HCPCS billing unit that needs to translate, and they're just billing out one unit or a lower number of units than should be. I see this all the time. A lot of EMRs nowadays can be set up to appropriately adjust those units when the medication is administered in the system. However, you still would want to double check and just make sure you're not taking it for granted and making sure it's set it correctly. The other thing I see that happens is incorrect CPT codes are being used. I see this a lot when there are medications that have different formulations, different doses. They are using the incorrect CPT code, or they're continuing to use a temporary code or something like that, and they're not getting their full charge and reimbursement because of this. So that is something you also need to do, is make sure all the CPT codes that are getting billed out are correct for the medications that are being administered. Not just the name of the medication, but also the formulation dose as well. The other mistake I see is outdated billing, like undercharging per unit, because the last time someone updated the charge prices on the medications was last year, 2 years ago, 3 years ago, 5 years ago, not realizing it's something that changes often, and undercharging. So there's either a very small allowed amount adjustment, contractual adjustment in there, or you're getting the full amount you're billing out for without any contractual adjustment because you're not billing high enough. That is something, and a reason why I'm doing this video is to bring to your attention that this is something that needs to be updated frequently. The last thing, and I see this with other CPT codes as well, not just medications, is practices will pick a charge amount not considering their highest payer with their best contract, and they don't bill high enough. And maybe Blue Cross is your highest contract, and you have a large volume of Blue Cross, and every time you bill out this medication, you're not billing high enough and you're not getting full reimbursement. And that's not okay. You have to look at every contract and see how much you're getting reimbursed by payer, by CPT code, by the billing unit for specifically medications, to make sure that you are getting everything you deserve when it comes to billing out and getting paid for these services. All right, so here is a summary of what you're going to do. You're going to take the ASP pricing for this quarter. You're going to look up all of your medications and consider their billing units and how much your ASP is plus 4.3%. Don't do 6% because you probably have a sequestration. So base it off ASP plus 4.3%, and that's your Medicare reimbursement. Then you're going to go and look at all of your invoicing for the same medications and see how much you're paying per vial, per syringe, and then figure it out how much you're paying per HCPCS unit to compare apples to apples to your ASP pricing. Then you're going to go look at your reimbursement, your allowed amounts. You're going to see how much you're getting paid for those medications per unit by payer. But first, making sure that you're billing out everything accurately and appropriately so that everything matches. And you're going to do a simple calculation. Once you have this all spread out and boom, 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 you're going to take a very basic formula to figure this out. You're going to do your profit per unit, right? That's what we're trying to figure out. We're trying to get to what is our profit per unit per medication. So you're going to take your paid amount and you're going to subtract it from your purchase cost, okay? That will tell you what your profit per unit is. It could be a loss per unit. Keep that in mind, like we talked about in the examples, but you're going to take your paid amount, assuming it's all accurate from your insurances, you're going to subtract it from your purchase cost, and you're going to get what your outcome is, whether it's a loss or if it's a profit and how much. Then if you wanted to drill it down even further, you could figure out how many times in a month you bill out that medication at that dose. How many patients, how many times, it might be the same patient every other week or something, but you're going to figure out how many times in a month for each payer that you offer this service to a patient and get paid for it. And you're going to find your overall profitability, hopefully, or loss, right? So you could say that you billed out $1,000 and they paid $730. It costs you out of pocket $685. So you're making $45 profit per treatment. But then you see that you see 30 patients per month that receive this medication. So that is taking 30 times 45, and that's $1,350 a month margin profit per month for that medication and that payer. You don't even have to drill down to the payer level if you don't want to. I think it's a good idea personally, but you don't have to. You could do it just as a generalized service and that CPT code, but it's not going to be as thorough, okay? It's important to do this because you might think you're profitable and maybe you're not with certain payers. I know with United Healthcare, they were very low on some vaccines and we had to stop giving them because they would not negotiate with us. And I knew just based off what we were paying at the wholesaler of so much money and how much on our contract it said they were going to pay us wasn't even close. And so I knew it wasn't even worth trying to do all of the data collecting after opening our doors because we were going to lose money right away. So I talked to the doctor. We tried to talk to the insurance company about it. They weren't open to negotiating. We were a new practice. So we said, okay, we're going to have to send patients somewhere else to get that vaccine. It's very unfortunate. It's an inconvenience for patients, but at the same time, we were running a business. You have to make sure that you're making money, especially nowadays with how much everything costs and the way that insurances reimburse. So what do you do if you notice that you're underpaid? Well, you would first want to ask your payers how they calculate the reimbursement, what it's based off of. Are they using an old ASP? Because if that's the case, they need to update it. If it's something else, then you need to be able to understand that to be able to have a conversation and come back to them for negotiation. If you're going to appeal or request an update, you're going to have these old ASP files and the current ones to support your request. So if you find out that they're using a 3-year-old ASP, you can pull that up, pull up the current one, see the comparison in the charges and the reimbursement, and then show them how outdated they are and use that as leverage. Negotiate with your payers if you have a very thin margin or you're not making money. You have to go to them and say, look, I understand you're using the most updated ASP and that's fine, but this is how much I'm paying for the drug. I've asked for discounts. I've shopped around. This is the best I can find, and show them all of your pathway and documentation of checking that out. And then show them what the reimbursement is and how small your margin is, or if you're losing money, to see if they're going to be willing to come up a little bit. But you have to have all the supporting documentation and figures in order to do this. Shop around to different wholesalers. Maybe you can join a GPO, a group purchasing organization, with other small practices in your area. See if they're getting discounts. Talk to your representatives at these vendors to see if there's anything they can do after your findings, and tell them what you're coming across, because they don't want to lose that business. So they may be very willing to work with you and assist you with getting a better deal, or even giving you tips on what other practices they deal with have done with insurances to try and get higher reimbursement as well. Specialty pharmacies tend to have a little bit better understanding of all of this, right? Because they have to purchase drugs. So any of the drugs with a high risk, loss probability, potential, I would definitely try to use a specialty pharmacy for those, the really high expensive medications, because they're probably going to be able to really help you in this area, or at least be able to work with you, okay? You can consider sending patients to infusion centers or pharmacies for medications that just are not going to be profitable, and you're losing money at the end of the day, and you can't get negotiations to work in your favor with the insurances. You can always send people to hospital-owned centers for drugs. Those are kind of like your last-ditch effort, in my opinion, because you want to make sure that you make it as convenient as possible for patients to stay compliant with their treatment plans, and doing so is allowing them to get it at your office. But of course, reality hits, and you might have to reconsider referring them elsewhere for that service. But there's also something else that we used to do in our practice, and we called it brown bagging or white bagging. That is where either the pharmacy benefits would pay for the medication using the patient's pharmacy benefits at their local pharmacy or specialty pharmacy, and the drug would get shipped directly to our office to administer, which would be white bagging, where we aren't buying the medication's coming to us already processed through the insurance. We're just billing for the administration of the medication, so the pharmacy just sends it directly to us. Or you can have the patient brown bag it. Think of it as like a brown sack lunch, you know, going to lunch in a brown paper sack. They bring it in to them. So you call it into the pharmacy deals with the insurance, paying for the medication, collecting the patient cost share. Once that's all taken care of, patient picks it up, brings it into your office, and you administer it. There are also medications now getting indications for self-administration. I know Xolair now has that capability. So you could always have a patient come in, bring the medication. You could do a training, go through all of the safety stuff, all of the formal process of injecting themselves, what to look for allergy reactions, whatever, telling them the site and how to prep it correctly. I think there might be a CPT code even for billing for a training of that. I could be wrong, but I would look it up if I were you, if this is something you're interested in. And you can train the patient to do self-injections or self-administration rather than having to have the whole pharmacy situation, bring it into your office, especially if it's inconvenient for the patient to do all of it. If that's an option, you can explore that as well. Don't let your business bleed money. It could be a slow bleed like I'm talking about, or it could be a really big bleed that nobody has caught to stop it yet. But this is one of those areas where it's easily prevented to not lose money in a business or a practice just by simple monitoring. Keep an Excel sheet, keep a tracking sheet of your medications, how much you pay for them per unit, what the billing unit is, where you buy it from, what your current allowable is per payer, what the ASP plus the 4.3% is, and have an easy resource for you to look at. It might be a lot of work the first time you do it, but after that, maintaining it and checking it is going to be a lot easier. If you have any questions or comments about this, please leave that in the comments below. Smash the thumbs up button if today's video was helpful. Subscribe to my channel if you haven't already, and please share this video with anyone whom you feel would benefit. I appreciate the support, and we will see you next time. Bye-bye.